Oh, the pool? Yeah. Ah, seriously? I'm gonna follow you. I need to buy better highlighters. Yeah, that's what I'm doing. I'm gonna buy better highlighters.
Gusto mo? Nadala kita?
You're not using it?
Oo. Ano? Ganun, marami akong
Highlighter?
sakto.
I wanna replace one. I don't like my highlighters.
Ito mag-isa. Pagpapaalam.
All right, so I wrote out the expected findings, so let's start from the beginning of chapter 12. So IICP is how we're going to relate to this. Hence, ICP, increased intracranial pressure. Now, if it's not increased, we just call it ICP, intracranial pressure. But in this case, we're going to talk about an increased intracranial pressure. This can occur from lesions, brain tumors, or fluid, or a brain injury in the cranium. Okay, remember that your head or your cranium is an enclosed structure. Your brain sitting inside of it. Okay, so the lesion or fluid will take up space in the cranium, and this results in pressure increase beyond the acceptable level. So as anything swells or fluid, you will notice that it doesn't fit, so this pressure is trying to look outwards, creating pressure inside your head. This will lead to, again, decreased tissue perfusion. It'll lead to impaired neurological function and possible death. Okay, so brain tumors is the first thing that we're going to go over, and I wrote it out for you here. These can be benign or malignant. And they can also cover either one part of the head or both hemispheres, right? It can differ. The biggest thing is that there's two of them. Now, as the tumors grow, again, they'll put pressure on the head, inside the cranium. For health promotion and disease prevention, I wrote on there is no routine screening procedures. So there's nothing that regularly you go into your doctors, right, and they just regularly do a CT or MRI, that's not a thing. For one, exposure to radiation and the likelihood of actually finding a brain tumor. So until symptoms present, will the diagnostics be ran? And the symptoms or manifestations, expected findings, what have you, include dysarthria, dysphagia. You could almost think of some of these effects like someone having a stroke, right? Because of in strokes, which we'll go over after all this, the decreased tissue perfusion is what's causing that tissue death, and so you're losing function. Now in this one, it's the pressure, decreasing the tissue perfusion. So dysarthria, dysphagia, they can feel dizziness, right? Vertigo. If leaning heavily on one side of the head, they can have heavy paresis. So the opposite side will feel weakness, right? Weakness or paralyzed. Severe headache is probably one of the most common. And this could be noted that could be worse in the morning, when awakening. And it'll get better throughout your day, but every morning you wake up, it's worse. Worse in the morning, you can improve during the day. Change in cognition. So that means that they can have memory loss or learning impairment, right? To be able to retain information or recall information. Their personality might change. Paralysis, we talked about. Hearing loss. Facial drooping. And one that I want to point out with a little bit of emphasis is this one. Nausea, vomiting. Especially if it's like projectile with kids. But nausea, vomiting in general, if you haven't really ate, or it's not like a GI disturbance that you're like feeling, but you have like a very bad headache, like your head hurts, and then you begin to get nauseous or you do vomit, that would be like, if anybody's ever like that, I would definitely go to the ER. Because that nausea is being caused from the amount of ICP that you have. So without any other factor, right? You didn't eat something funky recently, or that you know might have like upset your stomach, you didn't drink any questionable water. Like, there's nothing that you're ingesting that's gonna likely cause a GI, but your head is also hurting because you bumped your head especially, or it's new, then sure. Now this is where things can change a little bit, okay? If you know you regularly get headaches, right? You're not gonna, and like it's a thing, like you have migraines, things like that changes it. But a new onset headache with nausea, vomiting, eventually or developing, it's not good. The other thing is I've seen people with migraines, like awful migraines. I'm talking about you get taken out for a day or two from your migraine. They can also develop from all that pressure and just discomfort, they develop nausea or vomiting as well. But again, if you know you have migraines and sometimes they get really bad, it's probably not common to assume like, oh, okay, I have a brain tumor, because you've had a migraine for years. It's just the pressure or the pain can be so bad that time. Does that make sense? So don't see somebody throw up and then like assume like, oh, they got a brain tumor. Like it depends on the symptoms that are matching. Does that make sense? Yes.
Is there a reason behind the being worse in the morning? Is it because they're like not moving?
Maybe in the fluid circulation. What's going on? So, I'm usually not one to really care about a lot of the chit-chatty. I'll just let you fail or then question why you're not answering things correctly. But if it's gonna disturb the class enough, typically in the past when it's gotten so out of hand, I'll switch your seats all of you around to be in alphabetical order. Because then it's fair game that if you continue to talk in class, I can write you up. And you won't feel that it's your group or your side or your posse. Does that make sense? I'm all for break time, chit chat, or do your thing. Please don't cause hallways.
Is there a reason behind it being worse in the morning, or is it just because?
I would assume that it's either the fluid accumulation or the fact that your gravity, you're laying down. You're not consistently, if you are having fluid accumulation like that, it's not consistently draining. Does that make sense?
Yeah, that's what I was thinking too.
And then it improves as they awake and they go out through the day. The circulation itself will help drain a lot of it out. All right, diagnostic procedures. Isha, yes.
The other day you were saying something, I forgot the name of it, but whenever the brain starts to come back down in the center.
A brain herniation. And we're gonna talk about it because this is the big reasoning for it with your increased intracranial pressure, with or without a lumbar puncture. The lumbar puncture just makes it worse because it gives an opening for the pressure to come out. So you're trying to, and I'll try to draw it out again. Diagnostics, it's pretty straightforward. X-rays, CTs, MRI. What you're looking for is obvious. Lesions, masses, fluid, anything that's pointing to an inflammation, because then if it's fluid, it's like what's causing it or how to drain it. If it's a mass, run a biopsy. If it's inflammation, find the infection. So that's what ended up happening. So you have CTs, MRI, PETs, and, sorry, I forgot one, lumbar puncture. Now we know all of these is, right? No pregnancy for these. No metal. Okay? With lumbar puncture, please don't forget, they cannot have, and it's very dangerous, or it needs to have a lot of precaution, or it might be delayed if they have such a high level of increase in intracranial pressure. Because of what we're talking about, the brain herniation. Okay? They can run a biopsy to try to identify the tumor. Now remember, for the herniation, what you're seeing is, if this is your head, and this is your brain, your spinal cord, right? If you puncture, so if you have all this pressure here, trying to come out of your head, and there's no way, remember, it's an enclosed area. If you do a lumbar puncture here, so you provide an opening, then now there's a way out. Just like when you pierce anything with like a water bottle or anything like that, the pressure inside is going to make everything try to flow out through that way. So if the pressure hole was open here, you did the biopsy, the lumbar puncture, then naturally it's going to want to find its way through the spinal cord. Now herniation, like we said, your brain is in your head, but it's not trying to force itself down the spinal canal. Make sense? Down the meninges. So, as it's trying to force that, that'll cause a lot of squeeze, cause a brain herniation. So if you do a lumbar puncture while that pressure is up, that is what you are likely to try to, that's what likely can happen. So you want to avoid it. A lot of doctors will wait, or what will they do? While they wait, you can give to decrease the inflammation. Or, if there's a lot of fluid, we will give mannitol. Okay? So, if they're going to receive any of these procedures, look at the client education at the top of page 71. If on anti-epileptic medication, these must be continued to prevent seizure activity. If on aspirin, they should be continued at least 72 hours prior to the procedure. This is to prevent intracranial bleeding. This is more for the LP and or biopsies. Heavily for biopsy though is the main thing for this patient education. Okay. Normally, pre-procedure activities can be resumed after recovering from the general anesthetic. Care of the incision, keep clean and dry. If sutures are in place, they will be removed 1 to 7 days later.
No.
Driving should be stopped until the follow-up appointment, if they're okay. Driving will wait until their follow-up.
That's right.
Now, nursing care, maintain oxygen, maintain pain airway, have seizure precautions, very straightforward. More importantly, let's go over their meds. So of course you can take NSAIDs, non-steroidals. Okay, we talked about corticosteroids. This is your dexamethasone, prednisone. And we talked about in the previous chapter about its complications. Talked about mannitol, which is a osmotic diuretic. Please don't forget how it works. It'll draw the fluid into the vascular system, so you watch out for circulatory overload. Anticonvulsants or anti-epileptics. Remember that a lot of them, you monitor their blood work, and they can cause blood dyscrasias. Additionally, you never stop suddenly. What's that? A lot of AEDs. Okay? For antiemetics, right, you can use the PPIs or HT antagonists to prevent the nausea, vomiting. Now, in most cases, if you look into professional care, what's going to happen is either radiation or surgery. The tumor is benign, especially, they're trying to just surgically remove it. So the craniotomy, which is the therapeutic procedure to relieve the pressure, is the one that we should focus on. You have craniotomy, pre-op. Explain the procedure. Of course, you get consent. Okay, don't forget to get consent. The client takes aspirin, not any anticoagulants I'm gonna put. No alcohol, tobacco. And then post-op, monitor not just their vitals, but their neuro status. And the thing to know is your Glasgow Coma Scale. Treat their pain. No straining. So whether it's for a bowel movement, coughing, sneezing, the bowel movements, make sure you use stool softeners, prevent any strain. They can develop periorbital edema and ecchymosis, meaning bruising and swelling around the eye. This is not uncommon, meaning it's normal, just cold compress. Check their head dressing for drainage. Two complications. We're not gonna go too much into detail, because they should be familiar with it, which are gonna be, if you look at the two, is SIDH and diabetes insipidus. This will be from your pituitary gland. The pressure or tumor building can put pressure on that, and now you won't have either too much or too little antidiuretic hormone. We'll try it out right now and some things to know. Again, this all goes back to your endocrine module in term 3. You master SIDH, PI, like when we say this is a complication, it's just easy to understand. It all comes together.
Mr. Armando? The
Yes.
client education, what is that towards? Is that towards the diagnostic procedures?
For this one, it's for the craniotomy.
The client education that you had previous.
This one. Which one? This one is for the meds.
Meds. No, before that, it was client education.
And then the craniotomy.
The clean, dry sutures, 1 to
it's
7
for the
days.
biopsies.
Biopsy?
Yeah.
Thank you.
Okay. So, complications. You have SIDH and DI. Diabetes insipidus. In this one, urinating too much and not urinating. It's too little, yeah. So too much urinating, too little. You're retaining too much. For DI, it's very easy to treat. What are we gonna give? Vasopressin. For this one, the option can be remove the tumor. Okay, so in SIDH you will have fluid overload. On this one you'll have fluid underload.
Defect.
Fluid deficit is the word that they use. Underload. Okay, now remember that this leads to hyper of your electrolytes. Hypernatremia is the biggest concern. While in this one it'll be diluted. Hyponatremia. Now, unlike typical fluid volume overload where we're diluted in the blood, you should also be diluted in the urine. But in SIDH, it's the opposite. Your urine will be concentrated. And it's the opposite here. Blood concentrate, urine diluted. Now, I write these words, but what does this mean? And if your blood is concentrated, all your electrolytes are, your electrolyte levels, I should say, are high. And in your blood, here your electrolyte levels are low. And remember, it's up to you to put these together. We should know our electrolyte levels. Potassium, no, hyponatremia 135, 145. Calcium, 8.5 and 10.5. So you have to know your levels, because again, it's really rare that they say, oh, you know, the blood is diluted, or that you're gonna see the lab level instead. Or they'll describe the function. So muscle weakness, cramps, right? Hypokalemia, seizures, cerebral edema, hyponatremia. So know your complications. Right side, page 71. There are 4 head injuries I need you to know. Now for this, it's very straightforward. I just want you to be, when it's described or what they suffer, I want you to be able to name the name. So they have a concussion, a contusion, diffuse accidental injury, and intracranial hemorrhage. Now a concussion occurred after a head trauma that results in client's change of neurological function, but no identified brain damage. So while there was a change in cognitive function, there is no brain damage or no bruising, no bleeding inside, no bruising. So this could be, if you notice, like when you hit your head hard enough, sometimes it just really hurts. But a description of this is like when football players are in a car accident, right? And then you're like a little like you can feel like a little lazy, a little fatigued, feel a little dizzy, you can feel a little lethargic. But if you do a scan, there's no bleeding, no bruising, no anything. So the patient suffered a concussion. He was rattled, there was no damage. Okay, your brain was just rattled. Now in a contusion occurs when the brain is bruised. This also is accompanied by a loss of consciousness, meaning they are out, they fainted, or were knocked out. Loss of consciousness. Stupor or confusion. And in this case, obviously there was damage, as you just show bruising. Bruising is bleeding. Diffuse accidental injury, widespread injury to the brain that results in coma and is seen in severe head trauma. This, you said the patient goes into a coma from the amount of brain damage that has been caused. A cranial hemorrhage. Is a collection of blood following the head trauma. So what do we do for our head promotion? Wear helmets, especially when doing dangerous activity. Avoid dangerous activities. Rock climbing, mountain biking, motorcycle riding, speeding, driving under the influence of drugs. Wear your seatbelt. Okay, this little list is at the bottom right of page 71. So risk factors include, right, motor vehicle accidents, drugs, sports injuries, falls, yes? All right. Expected findings. Amnesia. What's amnesia? Loss of memory. You forget what happened. Loss of consciousness. Unconsciousness. CSF leakage. So your cerebrospinal fluid might be seen coming out from either your nose or ears. Okay, and how do you know this is gonna indicate a basilar skull fracture? And then you're gonna check the way that you know, because they might just be bleeding, but what if it's CSF leakage, what will you look for? A halo sign. Now this is when you see some blood, and around it, you see this yellow or white ring around the drop of blood. So what you do to test for a halo sign is you're gonna grab some gauze or a napkin and you're gonna let one of those drops of blood fall down. Then it'll kind of dilute and the blood will stay in the center, and this clear white liquid or yellowish liquid will go around, like it looks like it's around like a membrane around that drop of blood. Okay? That's the CSF fluid. Now, manifestations. How do you know someone has intracranial pressure? It's done the expected findings. Okay, obviously, severe headache with nausea, vomiting. Altered level of consciousness is what I'm gonna put. It says deteriorating, so it's going down, so I put altered level of consciousness. Dilated or pinpoint pupils. Types of respirations, so they can be altered, which you'll see Cheyenne strokes. Respiration. Deteriorating motor function. Deteriorating motor function. So what this is posturing. So you'll either see decorticate or in worst case decerebrate posturing. And again, we went over how that looks like. And lastly, you have Cushing's triad. Late finding. And it's characterized by a severe hypertension with widening pulse pressure. And bradycardia. So, the three is severe hypertension. We all know what this looks like. Hypertension begins right 140 and up. 160 or higher is even worse. But what's a widening pulse pressure? High systolic, low diastolic. Most times, as your systolic rises, your diastolic does too. So for example, 120/70, 120/60 is pretty good. But then as you go to 140, you might see that your diastolic now goes to 75, 80, 160, 90, right? It's climbing typically with it. So that difference from systolic to diastolic, we call that a pulse pressure, okay? The difference, meaning take your top number and subtract, the difference is your pulse pressure. So in the case of 120/70, it's a pulse pressure of 50. 40 to 60 is decent, okay? But as you, in Cushing's trials, you have a severe head injury, you can notice that you might have a high systolic, but instead of having a 90/100, right, or whatever, it's rising, it might fall or be wider. So now you have a pulse pressure of about 120. So that's called a widened pulse pressure when the number is higher. Okay? Shortened is when they're really, really, really close. So in the case of severe head injuries or a lot of intracranial pressure, you'll see a widened pulse pressure. Now severe hypertension is obviously there because it's causing it, and bradycardia. Those three make up what's called Cushing's triad. Okay? Now don't forget that translates to, like, no one's gonna say like, oh, well, you know, like, we're trying to assess for Cushing's triad, and you're gonna be like severe hypertension, right, widening pulse pressure, bradycardia. But you can see the values, so you can see the blood pressure, or with respirations, what's bradycardia? Sorry, the heart rate, not breathing, Jesus. Less than 60, right? Now, in some textbooks, you'll see that they do the severe severe hypertension with widening pulse pressure. That's usually one symptom. It's combined because obviously the hypertension was causing it. With bradycardia, and the third one that they use in actuality is altered respirations, really high or low, or inconsistent. So if you see Cushing's triad as having those three, hypertension with pulse pressure, bradycardia, their heart rate slows down, and the respirations are funky, that's the true 3-1. But in your book, it makes it like just hypertension, widening pulse pressure, or bradycardia. But if you see altered respirations anywhere else, it's not uncommon that they'll put it in there. Okay, Cushing's triad. And of course, seizures with head injuries. Labs and diagnostics, again, CT, MRI, get imaging of how awful the injury is. Okay, nursing care. Support the family. Very generic. But what does this mean? Express your feelings. Tell me why you're concerned. You never give false reassurance. Especially because they can get difficult decisions like organ donation or having to discontinue care. These are all terrible decisions that might come with severe head injuries. So be cautious and supportive to the family. Check for CSF leakage. You have to report it, right? And you're the one checking to see if they're leaking anything. Implement measures to prevent complications, so then turn them every 2 hours. A footboard and splints. Monitor fluids and electrolytes. Seizure precautions, and we know what that should translate to. Even though their level of consciousness is low, you still explain to the client your actions. It's for dignity and doubtness. Because arguably, people in comas can't or shouldn't hear us or know what's going on. But we don't know. So you want to say what's going to happen, what you're doing. That way, if they can hear or are conscious, and they're just unable to move or say or express, at least they know what's going on. Okay. Monitor their respiratory status, so check their nerve function, their neural function. And for ICP on the top left of page 73, you'll see some of these actions and some of these big ones. So for increased ICP, okay, sometimes they'll place a monitor into their brain to monitor how much pressure is in their head. You want it to be 10 to 15 millimeters of mercury. Okay? You want it to be between 10 and 15. Some places use 10 to 20. You definitely don't want it to be above 20. But that sweet spot right there is between 10 and 15. No higher than 15, no lower than 10 for their pressure inside of their head. Now, ICP can be increased when you're retaining too much carbon dioxide, hypercarbia, you're flexing, okay? Or the head of bed is less than 30 degrees. So where do you want to maintain it? At least 30 degrees for your head of bed. Because this will cause ICP if it's too low. You're putting more pressure on the head. Elevate the head of bed at least to 30 to reduce ICP. Maintain a neutral position, meaning straight. Administer oxygen. Give them stool softener so they don't strain. Cough suppressant so they're coughing. Okay. The biggest factor to take away from the actions are maintain their head of bed at least 30 degrees. Okay? For your medication, the key one is mannitol. Don't forget how to administer or draw it with a filtered needle. Make sure it's filtered some way. Check for fluid overload. Right, symptoms of heart failure, congestion. And the other big ones are anti-epileptic drugs. Check CBC. Don't stop suddenly. Big problems with it. For Phenytoin specifically, right? Watch their frequent oral hygiene to prevent gum overgrowth. Opioids, to check for respiratory depression, sedation, retention, right, urinary, constipation. And the big thing with opioids is that since it can cause respiratory depression, sedation, remember that this should be a factor when evaluating their level of consciousness. Because they might have a decreased level of consciousness with opioids, so you want to be careful with it. ICP, it can happen, yeah. Okay. Retention, they're supposed to say constipation.
You got it.
But it's still there, constipation.
How about
Good?
after ordering?
Hungry?
You underage after ordering.
We can't take too long because we got a lot to cover.
I have no clue. I was looking for it in the book also, I can't find it.
Yeah, let's take, back at